I think there were a lot of opportunities along the way for him to have had a diagnosis, but it took pretty much kind of a crisis year in first grade for us to really seek help.
He's such a textbook case to us. We knew exactly what it was, and we were so grateful to finally have the diagnosis. It was such a relief to say, this is what it is. It's not us. We're not terrible parents.
I was very disappointed with the way things were handled in first grade. I thought that most teachers would have some knowledge of hyperactivity and some understanding, and I didn't really feel that that was the case. We've had some excellent teachers after that. We've had very cooperative. We've had an extremely cooperative school, a very cooperative principal.
My specialty is internal medicine, but of necessity for obvious reasons, and because of the need in the area, which is probably no different than most other areas, but there don't seem to be many physicians who are acquainted with even the diagnosis of ADD, and particularly not the treatment.
Several times you get what I might call a gut instinct when you're dealing with a student that, hey, there's something there that reminds me very much of my son, for instance, and that's usually how I draw the comparison as to whether I feel a student may be ADD or not.
All About Attention Deficit Disorder, Part 2. Dr. Thomas W. Phelan is a clinical psychologist and nationally known expert on ADD. He is also the parent of an ADD child. In the first tape of this series, Dr. Phelan described what attention deficit disorder is, how it affects the child in different aspects of life, its developmental course, prognosis, and possible causes. Dr. Phelan will now explain how ADD is diagnosed and point out a crucial and often misunderstood problem in diagnosis that causes many ADD children to be overlooked.
Thank you. We're going to talk about diagnosis with attention deficit disorder. Diagnosis with ADD has a catch to it, or a trick to it. It's very important that you know it. Some of you have children that have already been diagnosed. Those of you who haven't can still run into this, and it can still pop up at different times and cause a good deal of difficulty. The problem with diagnosis with attention deficit disorder is this. As I mentioned before, a lot of the kids will sit still in a doctor's office. Okay, now, if they sit still in a doctor's office, how is the doctor supposed to see the ADD symptoms? He's not going to with 80% of the kids that are attention deficit. Some of them he will. I've had kids tear up my office, but usually they'll sit still in my office and they'll tear up the waiting room. But since this problem exists, it's different from cancer. I think you have cancer, I may have to do a biopsy, look at a tissue sample and see what's going on. If I think you're a paranoid schizophrenic, I may have to talk to you, see if there's auditory hallucinations, word salad, delusional material, and this type of stuff. I have to directly observe you. We do also have to directly observe the ADD kids, of course, but the other thing that we have to do, since they're going to be good in our office a lot of the time, is collect information from a lot of different sources. So we collect information from a lot of places, from before, from now, from teachers, from parents. We do use office observations and so on. But the catch is the diagnosis with ADD is much more information collecting most of the time than direct observation of the child. And that's very important to keep in mind. I've ventured to say some of the time, although it sounds terrible perhaps, that I could diagnose at least 50% of the ADD children that I've diagnosed without ever having met them. Now, that would not be good clinical practice, but you do need to get information. Most important information you get is really represented by you here today, and that is information we get from teachers and information we get from parents. The kids are hilarious. You get all kind of stuff from the kids. Sometimes you get good information. Sometimes you just get wildly inappropriate or way off base comments that really don't do you any good. The process we go through in diagnosing ADD, we really call it a screening a lot of the time, is first of all, we'll get together with parents normally, unless the kid's an adolescent, and we will ask them what are their concerns, what are their presenting complaints. And what we do is we take the presenting complaints that the parents mention and we compare them to that symptom list of 8 symptoms that I mentioned to you before. How well do they match up? What we do next is we do a developmental history with the parents, talking about the kid's development from infancy, even before birth, infancy, and on up to whatever age the child is at the present time. What do we do with that? We match that against the developmental history, the course that I described to you before, and see what kind of fit you get. We will then take a look at a family history. Okay? And what are we looking for? Well, the first thing we're looking for is ADD in mom or dad when they were kids, but we'll also look at some of the other things that may go along with it, such as the psychosis, depression, alcoholism, sociopathy, and that type of thing. We'll do some questionnaires, often the Connors questionnaire, although there are a lot of others that are available now. We have some situations questionnaires that are borrowed from a fellow named Russell Barkley. We will collect a lot of school information, which I'll explain in just a second. We will interview the child, and then I'll talk about the contribution of the physical and the neurological, because that's a little confusing. So all this information really needs to be collected. It doesn't necessarily have to take a whole lot of time, and it doesn't always have to have the parents present in the office to be able to get it. The school information that we gather includes, number one, grades. Report cards going all the way back to kindergarten. We prefer to get the report cards rather than a transcript if we can get it, because the report cards often have very helpful comments from the teachers, in those for each quarter where the teacher writes what this kid was like. And those comments are often very enlightening when it comes to ADD symptoms. The only quarter where those comments are not of any use is the fourth quarter. We'll get a lot of report cards with an ADD kid, and it'll say, first quarter, kid's driving the whole class nuts, he'll never shut up. Second quarter, still doesn't finish his work, always bothering his neighbor. Third quarter, we need to have another meeting because the misbehavior is continuing in school. Fourth quarter, enjoyed having you in class, have a nice summer. But we always figure the teachers are trying to end off the year on a positive note, and that's okay. But those report cards are very, very helpful. We also like to get achievement tests. Achievement tests are like the Iowa Basic Skills, the Stanford, the Metropolitan, or whatever. These are very helpful for a number of reasons. One is, if they're measuring what they're supposed to measure, they're telling you how much is this kid actually learning in school. Some of our ADD friends have grades that are rotten, but their achievement tests are up to grade level. That's very reassuring. That says that even if the kid is not doing well grade-wise, they're learning what they're supposed to be learning. You can also do kind of a inferring of an IQ from the achievement test, which isn't totally cricket, but it'll give you some rough idea of the intellectual ability that the child has. And you can look for the typical ADD scatter on the achievement test, and that can tell you something as well. School information, we also get teacher observations, either talking to the teacher directly or using the Connors questionnaires. If psychological testing has been done, we want to see it. If medications have been used, we want to know what they are and what they were for. And if special education is being used, we want to know what it is and why. If it's LD resource, BD, just not special ed, but chapter 1 or something like that, we want to collect all this information so we have some idea how this child's doing in school. Now, if you're into ADD screening, one of the questions that often comes up is, what about psychological testing? And this gets to be a little tricky. The problem with psychological testing, I'm talking about, like, say, giving them a Wechsler IQ test, some achievement tests like a Woodcock-Johnson Part 2, some tests of processing ability for learning disabilities like the Detroit VMI, some other things like that. The problem is, some of these ADD kids, because testing is novel and interesting, intimidating, and one-on-one, will do just fine in the testing. Other kids, their ADD symptoms will goof up the testing so that we don't get an accurate IQ and we don't get an accurate LD screening. Problem is, we don't know which kids are which before we test them. So what can you do? Well, there's a couple things you can do. One is you can try and do a guess based on what has this child been like in one-on-one situations in the past. Does he tend to be able to show his best behavior and sustain it for a couple of hours, in which case we might want to test him off the meds and take a chance. The other thing that we do some of the time is if we think a child might be a medication candidate, what we'll do is we'll do a medication trial first, try and adjust it. If we get good results, then we'll test the kid on the medications, hoping that the medication takes the ADD out of the picture so that we get an accurate IQ and LD screen. The problem I found in most school systems when it comes time for the staffing is that this question is not even discussed. They just test, or they don't test based on other considerations. But if you're a parent and you're going through this, test them. Even if you're doing your kid's in special ed and you're doing your 3-year re-eval, if the kid's on medication, he should be tested on medication. Sometimes people say, well, I want to see what he's like just on his own. Well, I don't want to see what he's like just on his own, because if it goofs up the test results, it's no good. And if you're getting test results out of staffing, whether you're a parent or a teacher, whoever, make sure the psychologist reads to you the behavior and attitude section of the psychological report, which tells you basically how testable was this kid. We've had kids that are so wild, they come up with an IQ of 74. But you find out the kid was crawling under the table, beating the examiner over the head with the whisk manual, and doing all of the kind of stuff, trying to escape from the room. And this kid basically was not testable whatsoever. So please look into that if you're getting into it. We do interview the child. If they're over 12, we see them first. Under 12, we see them after we talk to their parents. We expect them to be restrained, not to show hyperactive behavior in the office for the most part. We ask them questions about home, social life, school. We take with a grain of salt what we get. Sometimes we'll have them draw pictures or do other things to try and relax them while they're talking to us. And occasionally we'll give them brief tests of concentration. These we have to take with a grain of salt too, however, because it's a one-on-one situation. A lot of these kids will show their best behavior in the office. What about the physical and the neurological? Physical can certainly be helpful. It's nice to know that the child is healthy physically, that they're allergy-free, that their diet, their nutrition is adequate, that their sleep habits are reasonable, and so on. Some people believe that blood screenings are useful. Some people think that high concentration of lead in the blood, for example, could complicate an ADD picture, or thyroid problems might want to be ruled out. So physical can be useful. What about a neurological? Schools still have a penchant for referring ADD suspects to neurologists. Now, that's fine if the neurologist knows something about attention deficit. But very often what will happen is the most a neurologist can pick up in an ADD evaluation are soft signs, which is some fine, gross, and gross motor coordination problems, or things like motor overflow, where you say to the child, wiggle your finger, and he goes like this, and he wiggles the whole hand. But a neurological cannot be a definitive diagnosis for ADD. The developmental history, the presenting complaints, the family history, all that other stuff is much more telling. What about an EEG? The EEG is the electroencephalogram, not the cardiac, but the brainwave test. There is no pattern on an EEG that says definitely that a child is attention deficit. They may have a tendency toward more slow wave activity, but there are many, many ADD kids who have perfectly normal EEGs, and there's plenty of normal kids that have abnormal EEGs. So routinely doing an EEG, we never recommend for ADD. An EEG may be indicated if you have a child where you suspect epilepsy, some other kind of seizure disorder, headache problems, or a recent onset of inattention. Those times an EEG may be useful. But an EEG, considering it costs $150 to $200, unless you have good indication for doing it, and suspicion of ADD by itself is not good indication for doing an EEG on a regular basis. So we don't always do that. What you need to do really, if you're going to find a doctor, is you need to find somebody who knows something about ADD. Could be a pediatric neurologist, could be a child psychiatrist, could be a psychologist, could be a child psychologist, could be a psychiatric social worker. A lot of these people will need medical backup if medication is in order. But it could be any of those, but you've got to find somebody who knows attention deficit. Otherwise, you never know what you're going to get. So we collect all this information from the screening or from our evaluation. Then we have to put it together. So we have an integration problem. The first thing we're looking for here is what we call an across-the-board pattern. And that means a child who has all the 8 symptoms, or pretty much the full florid picture of ADD with hyperactivity. And I would say about half the time, especially in the younger kids, we'll get that. Many times parents will attend this workshop and they'll walk out of the workshop saying, that's my kid. I've had parents tell me, I think you've been living in my house for the last 15 years because everything you said about my child applied exactly to him. So sometimes it's pretty obvious when that happens. However, there can be some exceptions where you get a child who may be ADD. Now, some of them aren't ADD, but you get a child who, say, is ADD, but there's some blips in the symptom picture that can throw you off. And I'll tell you what some of them are. You may have some ADD kids who have good social skills. And they really, they have friends and they do okay. In fact, ADD and hyperactivity and social skills are interesting. There's a very fine line between being too bossy, which a lot of these kids are, and you go just a little bit over this way, you're a good leader. Just a few personality characteristics can take you over here. It's a very fine line socially between being hyperactive and you go over here and you're the life of the party. We have a lot of hyperactive kids that are appreciated for their hyperactivity. I have a friend of mine, and we think she's hyperactive, ADD residual. If all of you were having a cocktail party, she could come in and take over the conversation. Just one person versus 190 of you. So, she should rent out. If you have a party, and nobody knows each other too much, invite this gal over, charge $50 an hour. She'll get everybody going. Real lot of fun. But there's rough edges on it as well. But some kids have good social skills. Okay, so that's one thing. You may also find a child who is shy. Now, a shy ADD child in public, maybe not with the family so much, but in school, may not show the hyperactive acting out and the impulsivity and the blurting out and all that because they don't want to embarrass themselves. But when they come home, it can be like a hydrogen bomb going off. So that's another pattern that we get. That was the one that was sort of typical of my son. We'd go to school and we'd have teacher conferences and they'd say, oh, he's doing so well. In fact, he's kind of quiet. And I'd peek over the teacher's shoulder like this to say, what's the name on the file that she's got? Because when he'd come home, it was often like a bomb going off at 3:30 in the afternoon. If you have a child who has a high IQ, you can have ADD kids who have a high IQ, and like I said before, they may actually enjoy school. If they're so smart, they can get the work done quickly, they can be reinforced for their success, they may do okay in school, and then the symptoms show up socially and at home. So you may get an exception in the symptom picture that way. You also will get exceptions in the symptom picture, obviously, if you don't have hyperactivity. If you have ADD without hyperactivity, you're going to have a child who's going to show less impulsivity, less emotional over-arousal, and those types of things. And so you won't have the whole full-blown 8 symptoms. And finally, we get a few kids who have been, one way or another, kind of like only children. Some of these kids were raised, and either they were an only child in the preschool years, or when they were preschoolers, the other kids were so old that they weren't really around, and they had reasonably attentive, competent parents, and no sibling rivalry to bring out the worst in them. And so they get through the preschool years pretty well, and then boom, they hit kindergarten or first grade, and they start showing, a lot of ADD symptoms. So sometimes you get a change like that. If you get a situation where it's that's my kid and you know they're ADD, we're going to talk about the different treatment approaches in a minute. If you have a child where the diagnosis is ambiguous and you're not really sure, what are you going to do? Well, you say, my kid has 3 or 4 of the things on the symptom list, and one of them is the inattention, which you have to have. But if 4 of the others, he doesn't really have so much. So what do we have here? Well, it's hard to say. What we'll do in this situation a lot of the time is what we call diagnosing by treating. We may try something. We may try a daily sheet with the child to monitor him more closely. We may try a behavior mod. We may try the 1, 2, 3 magic program. We may try medication. See what happens. And then we try and reason backwards and say, well, if this didn't work, then maybe this is the problem. If this did work, maybe this is the problem. It's not a perfect way of going about it, but you have to do something. And if the diagnosis is foggy, which it often is, this is one way at least of trying to do something as well as clarify the diagnostic picture. So diagnosing by treating sounds a little funny, but it can be a very useful tactic.
We had gone through a number of years of being told, well, he's just an active child, wait till he gets to be a little older, wait till he gets into school.
Someone's got to say, hey, raise the flag, there's a problem here. Someone take a look. But that wasn't done. It took 7 months before we really had someone take a look and say there is something wrong.
At the child care center, we're pretty low key about it, but we'll discuss it with the parent, and they'll deny it. And then 2 years later, the mom will come back, or I'll hear, you know what? You were right. There is a problem, and maybe I should have paid more attention.
I think for us trying to diagnose ADD did take some time because we ourselves had to be convinced that there was a problem. The teachers came to us at school, said they thought my son did have a problem with ADD.
Well, the first time I really had any education dealing with ADD is when I went to an in-service held here in DuPage County, at which Dr. Phelan was speaking. And by that time I was pretty frustrated in trying to deal with my son, telling myself, you're a special education teacher, you should be able to deal with these behaviors. What are you doing incorrectly? And as he started outlining the characteristics, I started to realize, wow, I have an ADD child at home.
And when I found out there was indeed something wrong, it was a really mixed emotion. I was thrilled on one hand, and on the other hand, I was very frustrated because now what? Where do I go? How do I find out about this?
Now you know what attention deficit disorder is and how it is diagnosed and evaluated. Dr. Phelan will now go on to describe the different ways of treating the problem, including counseling, educational interventions, parent training, and the use of medication. It's a long road, and there is no cure, but there certainly are things that can and must be done. The first component of a successful treatment program has to involve education and counseling for both parents and child. Getting accurate information about attention deficit disorder and dealing with your feelings about it is absolutely critical for everyone involved.
Yeah, it's very helpful to have other moms to talk to. Being that we both work with ADD people in general, most of them call us and ask questions and information, which is good for me to share too, and for them to feel relieved, and then I feel relieved knowing I'm not alone, and it's crucial to have that support group. It is crucial.
As I mentioned before, there is no cure for attention deficit disorder. That's the bad news. The good news is there are some treatments for it. If you do have an ADD child, then you're in for a kind of a long project, and what I'm going to do is describe to you some of the tactics that you can use to manage the child over the long term. If you have a 6-year-old right now, you've got really 12 years more, at least, to where you're going to have to be actively involved in dealing with the child. The thing that's recommended in the area of treatment these days is the term multimodal, which some of you have heard. Multimodal means you need to attack the problem from a number of different areas. What we're going to talk about is counseling and education. We're going to talk about educational interventions at school. We'll talk about behavioral management and the 1-2-3 Magic program. And then finally, we'll talk about the somewhat controversial issue of medication. Counseling and education is really critical, and by education here I mean educating parents and the child about ADD. I'm not talking about school. And counseling can be very helpful. It doesn't necessarily have to be a weekly project, but it is very useful for parents and for the child as well. You can argue, say, is it therapy or counseling if somebody tells you that ADD is not really your fault? It gets rid of a lot of guilt, so it's probably therapy and counseling. So we do stress a lot giving people information. We want to make them understand ADD is nobody's fault. We're trying to get rid of guilt in the parents, and we're trying to minimize some of the anger that they may feel toward the child. We can't get rid of all of it, but we can sometimes minimize it and teach them to do what we call think ADD. It means you think this kid didn't ask to be this way. This is the way he is. It's not totally his fault. He's not here to drive me crazy, but I am stuck with the job of managing him as well as I can. We also in counseling talk about things like the difference between reasons and excuses. ADD is a reason why a child underachieves in school. It's a reason why he has a temper tantrum when the snack bar runs out of hot dogs. It's a reason why he beats up on his sister. But if you catch him beating up on his sister, he's pounding away and sitting on her on the floor, and you try and discipline him, and he says to you, what can you expect? I have attention deficit disorder, and I have a problem with emotional overarousal. That's an excuse, and we're not going to let him get away with that. So part of counseling is to deal with that. We also spend some time doing what we call self-concept restructuring with both the parents and the kids. We try and teach people to think more realistically about themselves. It's natural for human beings, even if they don't run into the stress of an ADD child, to be overly self-critical. If I say to you, if you did 20 things in the course of a day, 18 of them right and 2 of them wrong, which do you think about at the end of the day? You're likely to say the 2 that I did wrong. I say, what did you do with the 18 that you did right? You're going to say, I forgot them, or I took them for granted. That's not really very fair, but we all tend to do that. So using that kind of principle, we try and get people back in touch with all the good things that they do, and we try and prove, if it really makes sense, that these people, the kids and the parents, are basically decent, competent persons doing the best they can to deal with a difficult situation. I don't like to get into the stuff where they say, oh man, you are the neatest person in a world, and you are just so fantastic, and that's the way I'm going to build your self-esteem. Somebody says that to me, you're the greatest person I've ever met, and you're just the neatest person in the world. It couldn't possibly be true, so I'm not going to take it very seriously. And if I have a negative self-esteem problem, I'm going to go back and say, well, I know I must be right. I was a jerk in the first place. And so it's not going to make a dent. What about individual counseling and therapy for ADD kids? This is a controversial issue. There are a couple of kinds of counseling. One is what they call social skills training, and another is what they call self-control training. Social skills training is where you try and teach these kids to get along better with other children. The research on social skills training to date, unfortunately, is rather ambivalent. It's kind of mixed. It's promising, but there's a lot of problems with it. To illustrate the problems, tell you what often will happen. We'll have a child who has a problem getting along with other kids at school. Social worker at school starts a social skills training group involving this child with several other kids from the school. They get together for several months, and lo and behold, after several months, this child is getting along much better with the other children in his social skills training group. And he continues to beat the hell out of the same kid he's been beating up all year on the playground. The problem here is what? The social skills training did not generalize from the group to the playground. And the thing that drives us crazy in this business these days is lack of generalization. But it's being worked on. So there's some promising things happening. I'd have to say, if it were my child and he had social problems and there were a social skills training group available in the school, I would probably take advantage of it, in spite of the fact that the results are unpredictable. Another kind of therapy is self-control training with ADD kids. Some people say, look let's be honest. The very symptoms that make an ADD kid ADD are the symptoms that make him unavailable for individual counseling. He doesn't pay attention in the first place. He doesn't remember what you just said. And in the heat of battle, he can't use something that he talked about 4 days ago. And so a lot of people will say, this is just not going to do any good. Other people feel like, well, we got to do something. Our answer to that, or my answer to that, is this. We usually try and evaluate how good a therapy candidate a child is. And we have a list of criteria. I'll just tell you a few of them. One is, the older the child is, the more likely he might be a good individual counseling candidate. Older, a lot of times, means over 9 years of age. Secondly, the smarter he is. The more intelligent these kids are, the better they can do. The more verbal they are, the better they can do. The more able they are to relate to a therapist in a non-defensive way, the better they're able to do, and the more they're able to bond with the therapist and form a good, kind of close, caring, honest relationship. So if you can look at those characteristics, you might say maybe this kid would benefit from it. But it doesn't necessarily have to be something that is done every week. I've had people come to me and they say, my kid's been in play therapy for 5 years. I think he's ADD and I don't think it's doing him any good. What should I do? And what I usually tell them is I think we should get a second opinion from somebody who knows something about attention deficit disorder, because this may not be too helpful. We also always involve the whole family. Now, it doesn't mean that the family and the kids come in always at the same time. You may still split them up, but we always have to have contact with the parents and also with the child. One of the things also that's extremely important is parent education and parent training. We'll talk about this a little bit later, some more, but if you are a parent of an ADD kid, I always say you have to be a professional parent. You have to have a discipline system that is systematic, well thought out, and is the best you can do. You don't want to be shooting from the hip with an ADD child. Also, in my experience, especially in the last 4 years, after doing a lot of workshops on ADD and getting involved in starting a support group in Illinois, and I'm part of a couple of large national groups, if you're a parent of an ADD kid, we have found that the support groups are invaluable for the parents. And I speak as a parent as well as a professional. I think that the things that people have gotten out of it are fantastic. And that includes anything from just sitting down with people and commiserating and sharing old war stories, you know, like your most embarrassing experiences in public, to sitting down and really talking about different ways of managing sibling rivalry. We tried to set up the support group so it respects people's desire for privacy, so that if they just want to receive a newsletter, they can do that. If they want to attend large groups and just sit there and listen, they can do that. If they want to be involved in small group discussions, they can do that. But I certainly, after seeing what's happened with this, I think support groups can be very, very valuable for parents and even for teachers as well.
It's my firm belief that medication cannot do it all. You know, we can't rely on one thing or the other. And the student and the parents and the teacher must learn how to do some sort of behavior modification. And I think the counseling helps promote that.
He was able to release it to somebody other than the parents or the kids or the rivalry or whatever, the teachers. But he was able to release it and feel better about it and try to understand it.
Yeah, there's a lot of work that you know, that he's had to do individually with the social worker and that we've had to do with him to help build his self-esteem back up.
I think the support group, especially in the past year and a half or so, we've been coordinating a support group in the western suburbs, and we've seen tremendous growth in this support group. We've had a lot of people join the group. We take a lot of phone calls from people who have just had their children diagnosed, and we've talked to them about different techniques they can use and encourage them in different things they can do, and it's been a real growth process for us.
As mentioned before, school can be torture for the ADD child. Unfortunately, it can also be torture for his teacher. How can you help both of them avoid disaster and have a productive year?
Our experience with schools and administrators in the beginning, I think, was a little more difficult. After we took the time to educate them, we brought in materials that we ourselves had received through support groups and counseling, which we passed on to the teachers and educators. They were very receptive and a lot more willing to work with the kids, and I think it's been very, very beneficial.
There are fortunately some things that you can do if you're a parent or a teacher, and we're going to focus on the teachers for a second, that can really help the teacher and the child have a much better year. It will not cure attention deficit disorder, but it can really help a lot. What I want to start with is just giving you a brief idea of some regular classroom tactics that a lot of people have found to be quite useful or even essential. If you have a teacher and they're not familiar with some of these, you might want to show them a copy of the tape and let them pick and choose which ones they think would be most useful for them. First of all, we talk about desk placement. Where should the desk of an ADD child be in a classroom? The answer, up in front, as close to the teacher as possible. There are a number of reasons for that. One is that more closely mimics the one-on-one type of situation that I said before ADD kids do best in. So a teacher's real close. If I'm close to you, I can just walk over, put my hand on your shoulder when you're off task, and hopefully get you back on track again. Secondly, another rule is you want to minimize the distractors for an ADD child. And what that means is you want them away from other things or people that move, make noise, and take him away from his work. You don't want an ADD child sitting next to a window that goes out to a hall, or a window that looks out over the playground. We had a child a couple of years ago who was having an absolutely terrible year. And when we investigated the situation, we found out, yes, he was ADD, but where was his desk? His desk was next to the window. What were they doing on the other side of the window? They were building an addition to the school. So this kid had ample opportunity for distractions. Also, if your desk is up in the front of the room, you will not be looking at as many people as you would be otherwise. Those of you in the back here, if you were ADD and you were sitting in a classroom, look how many potential auditory and visual distractors you have in front of you in the form of people that could take you off task. Those of you in the front, if this is a classroom, you just have me and the wall, and so it's easier to deal with. In addition to minimizing distractors and desk placement, another tactic that's very helpful is attention ensuring with the ADD child, and trying to make sure that you have their attention. One way to do this is by eye contact. Try and make sure they're looking at you when you're talking to them. Also, keep what you say short and sweet. As a parent or as a teacher, you do not lecture an ADD kid for long periods of time because they won't sustain the attention and they won't be able to focus on what you're talking about. Now, there are some kids that develop a very unique skill, and the skill is that they can look you right in the eye. They can nod at the appropriate times. They can laugh at your jokes, apparently, and they're not paying any attention to what you're saying. My wife says sometimes I can do that with her. But it's a unique skill. So what do you do with that? Well, then you do attention checks. Without trying to embarrass the child, you say, well, John, could you, tell us what the directions are for this assignment? Because ADD kids are often the first to start and the last to finish, or they never finish. And they'll start without reading the directions. And so oftentimes they'll do the whole thing wrong. For behavioral problems in the classroom, we'll use the 1, 2, 3 or the counting program, which I'll tell you a little bit about in a minute. For a child who's misbehaving. For a child who is off task, a very good recommendation for a teacher is a secret signal. A secret signal is where the teacher develops some nonverbal cue that they use that they will give to the child that they agree with the child means that he is off task and he's not paying attention. It may be that I walk over to you and I put my hand on your shoulder, and that is a cue to you that you're off task. It may mean that I stand there and put my hand on my hip. This is a little too flagrant, so we don't use that too much. One teacher said that the secret signal that she used was that when the child was off task, she would tug on her right earlobe. She said that was very successful, but by the end of the first semester, her earlobe was drooping down to her right shoulder. So you can use a number of different things like that. Another standard rule with ADD kids is structure, structure, structure. Try and do the things same time, same place, same way if you can. ADD kids do not tolerate change real well. What about special education classes? The issue gets a little confusing here. Some of you are aware of the fact that as we speak, there's a bill pending in Congress in Washington that is an attempt to amend the Education for the Handicapped Act, Public Law 94-142, to include ADD as a handicapping condition so our ADD kids can get special services like LD kids can. The bill is not likely to pass this time around. There is still hope for the future. Not all ADD kids need special education, and some of them are ADD plus LD. In some schools, the kids that are ADD and LD will wind up in special ed resource or even special ed self-contained. Some schools that seem to be more understanding or sympathetic will allow a child special ed resource simply for the monitoring that's involved, where the resource teacher is really a kind of a supervisor, study skills policeman. And the child may not really have what you would consider to be a full-fledged learning disability. And a lot of our ADD kids will wind up in BD classes, which is behavior disorder. I've found in my experience the last few years, it seems that parents are getting more and more turned off toward behavior disorder class placement. It's very hard to convince some parents that BD means better deal for their child rather than just BD. Parents' concerns, which are legitimate, are what about the company my child will keep? Will this make him worse? Will he have worse role models and so on? But the comeback question to that some of the time is, how bad off is he going to be in the regular classroom where he is the class clown, the black sheep of the class, he's sticking out like a sore thumb, which is harder on the child. It's a very difficult decision to make. So BD isn't always the answer. Sometimes it can help. A lot of times to qualify for behavior disorder, you have to have had 3 previous attempts at dealing with a problem that failed, and then the child may be placed in BD. I always threaten in these workshops to do a study someday in DuPage County of all the children that are placed in BD classes. In my study, what I'd like to do is get all of them together, do our ADD screening on all these kids, and find out how many of them are attention deficit children who are not being diagnosed or treated properly. And I would venture to say that the percentage would be very, very high. Another thing that can be helpful in school for some ADD kids is tutoring. But I'm going to warn you something. We have an old saying that says you never teach your wife to learn how to drive. The corollary of that here is you never tutor your own child unless you can guarantee me that it's going to be a pleasant experience for both of you. And we have families where they spend 2, 3, 4, even 5 hours a night struggling with this kid on tutoring homework kind of work. And it gets into be a royal battle. It's just a waste of time. If you're doing that kind of thing, my suggestion to you is stop right this minute. Don't ever do it again. You're going to say, what about his homework? Get somebody else to do it. But honestly, I would rather have you do nothing than go through that. You're not encouraging him in his relationship with you. You're not endearing him to academics. And I'll guarantee you're doing more damage than you are providing help for this child. Excuse me. Keep in mind, too, there are 2 kinds of homework. One is real homework and one is ADD homework. You know what the difference is? Real homework is homework that's assigned as homework. It's intended to be done in the evening. ADD homework is homework that the kid didn't finish during the day because he wasn't concentrating. And, of course, to deal with ADD homework, you have home and what you do in the evening, but you also have to take a hard look at what are you doing during the day and how could you change that so the child doesn't bring home as much. But if you are having royal battles every night with your child over homework, stop it. Almost any alternative is preferable to doing that. It's a miserable way for you to end your day, and it's a miserable way for your child to end the day. Sometimes what we'll use for kids as a non-biological intervention in school, if they're having trouble or to kind of monitor their behavior, is a daily sheet. Some schools have their own. We have one that we have worked up where we rate the child in each subject and his behavior, his academic performance, and then there's a part off to the side for an assignment sheet. And this comes home every day. The parents have a very brief meeting with the child, and then we periodically review how much progress he's making. If the child is on medication, it's a good way of trying to monitor progress from medication as well. So sometimes the daily sheet can be very effective.
It's very interesting that I would be asked about the effect that an ADD student has on the outside staff, not just the teaching staff. From a personal basis, I'm experiencing this right now. You tend to put more demands on the school in general when you have an ADD student. The need for structure in their life is so much more important, or I shouldn't say more important, but more imminent, that you have more demands. I am asking my son's junior high right now to constantly fill in forms, send them back. Teachers already have lots of things to do. The last thing they want to do is fill in one more form. It's very difficult sometimes just to remember to fill this in. I know as a teacher myself, it gets to be a lot of work sometimes. So you're asking administrators to make special concessions, and sometimes trying to understand, meet with counselors, speak with counselors. So it's additional time, it's additional effort.
As a parent or teacher, it's certainly not easy dealing with the often disruptive and chaotic behavior of the ADD child. You must know what you're doing, and you must have a kind, firm, and systematic method of discipline and training. Dr. Phelan's 1-2-3 Magic Behavioral Management Program can provide you with a way of helping the child and preserving your sanity.
Before we used 1, 2, 3, Kevin would want to spank. I would want to have him do time out or take away a privilege, or even if Kevin didn't want to spank, maybe I thought he was being too harsh, yelling at him. But now with the 1, 2, 3, it's pretty much cut and dry. This is the way it is. There's only one way to, basically one way to do it now, one routine. So now there's not so many disagreements about it.
We don't have a lot of time in this workshop to talk about the home management program. So what I'm going to do is to briefly introduce you to the 1, 2, 3 Magic program, just tell you a little bit about it. We use this, some of you are already using it, I know, at home, and we also use it in the classroom. Just want to tell you a little bit about it because some basic principles involved I think would be very helpful for you to know if you're not already aware of them. ADD kids present you with many, many behavioral problems, and it's very difficult to deal with all this kind of stuff. They can get you very emotional. They can get you talking too much. They can get you too excited. And they can get you totally buffaloed. Where we start with the 1, 2, 3 program is, first of all, we try and get parents to stop thinking of their kids as what we call little adults. A parent or a teacher thinking of a child as a little adult is thinking that the kid's just smaller than I am, but they basically got a heart of gold, and they're basically reasonable and unselfish. Okay? They're just shorter. All I have to do in a pinch when the kid's not doing his homework is give him the 5 golden reasons why he should complete his homework, and the child will turn to me and kind of stagger back like this and say, "Gee, Mom, I never looked at it like that before." Now, of course, that's ridiculous. Those of you who are laughing should be laughing. Kids are not little adults. In fact, one writer whose name I don't recall said that childhood is a period of transitory psychosis. Do you know what that means? I think some of you do. It means that kids, when they're little, are basically nuts. And whose job is it to make them sane? It's a parent's job and the teacher's job. Okay? But reasoning and words do not usually work very well with children. So if you think little adult, you're going to start talking to the kids. How many of you have tried reasoning and talking to your ADD children? Not only does it not work some of the time, it can also take you through what we call the talk, persuade, argue, yell, hit syndrome. And if you don't know what that is, it's a child who's not doing what you want. You try talking to them, that doesn't work. You try persuasion, that fails. You use arguing, you start yelling, and then maybe wham, you hit them. Now, I'm not suggesting you're all hitting your children, but I will suggest that one of the major causes of child abuse, and ADD kids are a more abused group physically, one of the major causes of child abuse is the little adult assumption. It's a parent who assumes that words and reasons should work with the child, and when they don't, the parent goes crazy. So what we do in the 1, 2, 3 program is we teach you a simple counting warning system that involves only 2 words. When the child is not doing what you want them to do, you use those 2 words. They get 3 chances, and if they don't make it, there's a consequence. We have what we call our no talking, no emotion rules, which means when you're dealing with the children, the less talking, the better, and the less excited you get, the better. If you have a child who's doing something obnoxious that you want to get them to stop, we have one tactic, which is the counting procedure, the 1, 2, 3. You can use that counting for the arguing, whining, fighting, screaming, yelling, teasing, temper tantrum, sibling rivalry, all the kind of obnoxious garbage you want to get the kids to quit. You will have 5 different tactics that you will use to encourage good behavior, positive behavior, such as doing homework, cleaning rooms, getting up and out in the morning, and things like that. You need different tactics for different types of behavior. If you mix your tactics, you will not be as effective. I use this in raising my own kids, and having one that was hyperactive. I think it helped preserve my sanity and my wife's sanity over the years in getting him up and successfully, we hope, out of the house. I toyed with the idea of calling the program, instead of 1, 2, 3 Magic, I toyed with the idea of calling the program The Art of Self-Defense, because that's what it felt like some of the time. So if you're interested in the 1, 2, 3 Magic, we do have some other materials available.
Along with a lot of other things such as parent support groups, finding out more about behavior modification, the 1, 2, 3 counting, those types of things. I think it's possible to, with a lot of effort and a lot of tears possibly, but it's definitely possible to improve the situation if you really work at it.
Get yourself involved in a support group and talk to those people and take whatever you can from them. Use 1, 2, 3 Magic for behavior management, and read some of the things that are out in the literature, and then try to look on your child as a special gift from God that was given to you to deal with.
Medication can often be very helpful as part of the intervention program for attention deficit. All parents, however, have legitimate concerns about this type of treatment. How do you decide? The first step is to get accurate and reliable information.
Medication for the child is one thing, but I think the parents need to understand what the medication is. A doctor will prescribe it, and most parents don't know what it is. And you have to go out one step further and say, this is what it's going to do for the kid, or it might do, and it may have side effects.
Unfortunately, the use of medication has become controversial. It has become much more controversial than it really needs to be. As I mentioned before, in the popular press, you're going to get a lot of negative things about the use of drugs with children. A lot of this information comes from the popular press, and it comes from people that are not very well informed. What I'm going to do this afternoon is try and give you some basic idea before we close of the facts about medication, what they are, which ones we consider using, the good effects, the possible side effects, so that you can be an informed consumer. And I also want to reassure you that a decision to use medication with an ADD child is your decision as a parent. It's not a teacher's decision, it's not a pediatrician's decision, it's not a psychologist's decision. So nobody, so to speak, can shove it down your throat if you are not in agreement with it. But you need to know what the facts. I'll do my best to give you an objective story about what the situation is with medication. If we get to the point in dealing with a family where we think medication is in order, first thing we do is we talk about the family's attitude toward medication, the child's and the parents'. Parents' attitude is always negative, but the negativity varies from mild to violent. Okay, so we'll discuss it with them, explain the ins and outs. This is where education is very important. The child's attitude toward medication is often interesting. It's often kind of the trooper mentality. They'll think, well, you know, if it helps, what's the big deal about taking a pill? And so they rarely will object violently to doing that. We will also explain to the family that it is only a trial. If the medication works, fine. If it doesn't work, we'll stop, or we'll try something else. But we're not going to have somebody take something if it doesn't work or if it has side effects. I always tell the children, the ADD children, that if you're going to take a medication and I'm going to have something to do with it, I will guarantee you two things. One is the medication has got to do you a lot of good, and number two, the medication cannot make you feel bad. And that's the way we operate. So we explain that to them beforehand. We also discuss with them contraindications for medication use. Now, the contraindications that I'm going to list apply primarily to the stimulants like Ritalin, Dexedrine, and Cylert, but they are ones that you should know in case you're at the point of considering medication for a child, or even if you've gotten into it. One of the contraindications for medication use is a generalized anxiety state in a child. Sometimes using stimulants for kids that are just across-the-board worriers will make them more anxious. For kids with specific phobias, it may not be the case. Sometimes the choice for an ADD child who is also very anxious is to start with an antidepressant rather than with a stimulant. A second contraindication for medication use is tics. Tics are involuntary muscle contractions, kind of a twitch like this. Sometimes it can also involve guttural or vocal noises that are repeated, like repeated sniffing, coughing, and so on. The concern here is about Tourette's disorder. Tourette's disorder is a childhood onset psychological problem, occurs normally between the ages of 2 and 15, strong genetic components. So part of a diagnosis should be to ask the family if there's any history of Tourette's. What scares people about it is that if it's very rare, by the way, but what scares people about it is if it gets really bad, it can involve not only involuntary muscle contractions, but compulsive swearing. I mean, out loud. And so you have a person who will, in social situations, utter obscenities, and of course that has a horrible effect on their life. The research really does not suggest that the stimulant medications cause Tourette's. The worry is that the stimulant medications may hasten the onset in Tourette's of a child who's already predisposed. And if we do have a child who goes on stimulants and they do develop tics, we usually take them off right away, and the tics will usually evaporate. Another contraindication is a family that's not good at follow-through. Some families seem very interested in the ADD diagnosis and in the child taking the medication, but they don't follow through. And a kid may get a good response to it, but he gets what we call the yo-yo effect. The yo-yo effect means he takes the meds, he's good in school one day, next day they forget he's terrible, next day he's good, next day he's terrible. And our inclination, and we've done this after a while with the family, is say, look, make up your mind. Either give the poor kid the meds regularly or forget it, because it's not fair to put him through this yo-yo effect all the time. And families vary a lot. It's kind of that family strength thing that I talked a lot about before. Families vary a lot in terms of how able they are to follow through. Another contraindication is psychosis. You would never give a stimulant medication to a child who's psychotic. It's very rare, so you don't usually have to worry about it. Age is a concern, not necessarily a contraindication. Usually with a medication like Ritalin, if you get under age 6, the side effects will tend to increase and the effectiveness will decrease. However, Ritalin has been used with kids down to age 3 in desperate circumstances. However, there are 2 other drugs that are used with ADD. Those are dexedrine and Mellaril, which are approved for pediatric use down to ages 3 and 2. And so in desperate circumstances, assuming the kid is really off the wall, the family has done everything they can, including the best they can do with a behavioral management program, and still the child is not doing as well as they would like, medication might be indicated. But generally, you're very hesitant about using it with a child that is under age 6. Finally, another contraindication is a concern about abuse. But before you jump to any conclusions, our concern is not about the child abusing the medication. The stimulants, Ritalin and dexedrine, are what they call Schedule II drugs, classified by the FDA, and that means they could be potentially abusable if you take handfuls daily. Now, our kids don't take that much, so there's virtually no evidence in the literature of ADD kids getting addicted to stimulant medications. However, there are a few situations, not real common, where you have a family go in, their child will be diagnosed as attention deficit disorder. They'll get a prescription of a stimulant for the child, and the kid never takes the medication. Who's taking it? The parents. Why are they taking it? Either to get high or for appetite and weight control. It's happened. It's not real common, but it's a contraindication. So if you had a family with a history of that kind of thing, you might be leery about getting a prescription for a stimulant medication for that child. What kind of medications do we use? Generally, the categories that they fall into are several. The most commonly used are the stimulants, Ritalin, dexedrine, and Silert. After that comes the antidepressants, which sounds funny using an antidepressant for ADD, but it just so happens that they can work. Norpinephrine and tofranil are the ones that are most often used, although there's a whole host of others that have been employed as well. A third type of medication is one called clonidine, which is actually a blood pressure medication. It's an antihypertensive, and we're hearing more and more about that now, sometimes also called catapress. And a fourth category is what they call antipsychotics or neuroleptics. These are medications like Mellaril, which is the one I just mentioned before. Those are rarely used, however, and I won't really talk about that a whole lot. Let's go back to the stimulants. If you look at Ritalin, which is the most used, probably 9-to-1 over all the rest of the medications combined, Ritalin is probably the most effective drug for attention deficit, working effectively in about 75 to 80% of the kids that use it. It doesn't always work, can have side effects that prevent the consistent use of it. But Ritalin can be a very effective medication. Ritalin, which is also called methylphenidate, which you may have heard of, that's the generic term for it. Ritalin comes in a 5, 10, and 20 milligram regular form, which if you take is supposed to kick in about a half hour to 45 minutes and last about 3 to 4 hours. That means a child taking Ritalin for a school day to cover the whole day has to take 2 doses, which many of you I'm sure know. You take one in the morning and then you take one at lunch. Ritalin also comes in a 20 milligram slow release form, or what they call the 20 milligram SR. The slow release is supposed to last 7 to 8 hours, and sometimes it works very well. But if any of you have kids on slow release and they're not doing very well after having done well on Ritalin before, it may be the slow release, because it's kind of goofy stuff. The problems you can run into with the slow release Ritalin are slow uptake. It doesn't kick in a half an hour. It kicks in an hour and a half, and the kid is squirrely the first classes of the day. Another problem is quick fade. It doesn't last 7 to 8 hours. It lasts 5.5, and the child is squirrely the last classes of the day. Sometimes the release is uneven. You get a blood level spike in the morning, 80% of the value in the first 3 hours, and then it drops off and he's getting virtually nothing in the afternoon, which would be close to the quick fade routine I just mentioned. And sometimes the slow release doesn't work at all. But before you can the slow release, and your child has to be in the 20 milligram range for 8 hours, because you can't break it, and that's the only dose that it comes in. But before you write it off altogether, you might try it if your child is taking Ritalin and is taking, say, 10 in the morning and 10 at lunch. But don't get a month's supply when you get it. We have a lot of families that do that. They get a month's supply of Ritalin, and they try it a week and it doesn't work, and they got 3 weeks supply of Ritalin slow release that they can't use. So be careful of the Ritalin SR. It can work very well. It's not like it's dangerous. It's just like sometimes it doesn't do anything. And don't break it. I had 2 kids once that smashed the Ritalin SR and took it, and it was very interesting. They had 2 opposite responses. One became a zombie and sat around for 2 hours just staring into space. Didn't hurt him, but he was zombied out. And the other became super hyperactive. He chewed the Ritalin SR, swallowed it, and became super hyperactive for about an hour and a half. So you cannot do that. The maximum recommended daily dose of Ritalin is 60 milligrams a day, 60 milligrams, which means you could have a child up to a 30-30. Now, that's not a law, it's a recommendation. So occasionally you'll find kids that go over that. The second stimulant is dexedrine. I'd have to say, in my experience, especially over the last couple of years, I'm becoming a big fan of dexedrine, especially when Ritalin doesn't work. If one stimulant doesn't work, there's still a 25% chance that another one will. Dexedrine, however, has a number of advantages. It's just about as effective as Ritalin. The side effect profile, which we'll talk about later, is fairly similar. But dexedrine has a 5 milligram regular form, which can last 4 to 5 hours. It also comes in 3 different slow-release forms, a 5, a 10, and a 15 milligram spantrol, they call it, which can last 8 to 9 hours. Now, that flexibility in slow-release dosing is really handy. If you have a child who's, say, getting older and he's getting embarrassed about going down to the lunchroom to get his lunchtime dose, or he's forgetting to do it, you're getting compliance problems, he doesn't like his appetite being suppressed, or whatever it is, the dexedrine can be very helpful. And I believe, although I still have to find some literature that supports this, that the dexedrine slow release is much more reliable than the Ritalin slow release. The problem is dexedrine is harder to get. The doctors, when they prescribe it, have to fill out a triplicate form, which they don't have to do for Ritalin for some reason. And one of those forms the doctor keeps, one goes to the pharmacy, and the third one goes to the state of Illinois. And I think a lot of doctors get a little worried about the state of Illinois kind of keeping tabs on them, prescribing a Schedule II drug, and they worried that maybe they get in trouble. Dexedrine tends to have a somewhat bad reputation as a street drug. Okay, it's abusable just like Ritalin is. But dexedrine is an excellent medication, and we've used it very, very successfully, especially lately, and that slow-release flexibility is really good. Dexedrine, milligram per milligram, is about twice as powerful as Ritalin. So if you had a child who was taking 10 milligrams of Ritalin per dose, he might take just 5 if you were switching to dexedrine. Cylert, the third stimulant, is only a slow release. It's supposed to last 9 to 12 hours. Some books say 18 to 24. Disadvantages, it takes 3 to 4 weeks to kick in some of the time. And so you're kind of waiting and waiting and waiting and waiting for it to start. If you had a child on Ritalin and you're switching him to Cylert, you can actually do both medications at the same time while you're waiting for the Cylert to kick in, which a lot of people don't realize, so the child doesn't have to disintegrate in the meantime. Cylert comes in real weird doses. 18.75 is the smallest. 37.5 is a pill that's twice that. The maximum on Cylert is 112.5 milligrams per day. Again, a very good medication, effectiveness just about as good as Ritalin, and certainly worth the try if the other stimulants did not work. Now, if the stimulants don't work, or if you have a child who has a history of either a lot of anxiety or a lot of depression, sometimes we'll start with the antidepressants. The antidepressants have good and bad with them. Antidepressants meaning imipramine, which is tofranil, or desipramine, which is norpramine. The antidepressants can sometimes last 24 hours just taking one dose before bed. Doesn't always happen, though, in a child whose metabolism is faster than an adult, so sometimes you have to split the doses, one in the morning and one at night. But the antidepressants can often have a personality mellowing effect, where they kind of, in a non-drugged way, help the child with his impulsivity, difficulty delaying gratification, emotional overarousal, hyperactivity, and even social problems. What they're not so good with a lot of times is concentration benefit. Antidepressants are not really real helpful in getting kids to concentrate better. Sometimes what we'll do in those situations is actually have a child take an antidepressant and a stimulant at the same time. When we get into this with some families or doctors, they'll think, now we're talking drug central. This guy's out of his mind. He's just pushing drugs, every way he can. Well, I can see how some people would feel that way, but the interaction between the two drugs is not a dangerous interaction, and the effects in a lot of people are very, very positive. I sometimes threaten, even though I'm a psychologist and I can't prescribe medications, I've threatened many times to invent a drug that is a combination of Ritalin and tofranil in the same medication, because the combination I've seen a lot of times where it's very, very useful for the child. One of the problems, as many of you know, with Ritalin is it only covers a school day. And a child comes home after school and it's the same kid. A lot of parents say, listen, this Ritalin is great, but this teacher gets the benefit of it. I get the same creep kid back at 3:30 in the afternoon. What's the good of this? Well, sometimes the other medications can help through the evening, provided that the family is doing something reasonable about dealing with the child's behavior and they're not aggravating the problem unnecessarily. And finally, clonidine, antihypertensive medication, comes in a 0.1, 0.2, or 0.3 milligram sizes. Also comes in what they call a transdermal skin patch, where you can take this thing, it looks like a Band-Aid, and you stick it on the child's skin, and the medication, believe it or not, is absorbed through the skin, and it can last a week. One of the problems with that is that ADD kids tend to be touchy, picky kids. So you try and place this thing on the back so they can't reach it, and high up on the back, but even there, they'll get it off. We have some kids that take it and they will do very well with it. Disadvantage of clonidine, it can take a month or two to kick in. Advantage of clonidine, it can calm a child down, have almost what you describe as a maturing effect on the child. Disadvantage, again, is that, like the antidepressants, doesn't always have a concentration benefit that's real powerful. Now, what about prescribing the medications? If we have a family, and we're going to get into using the medications, I'm going to give you the example of Ritalin since that's used more commonly. If you're going to start a child on Ritalin, the first thing you have to do is find somebody to prescribe it. We usually will use the pediatrician. If the pediatrician won't, we may look for a neurologist, we may look for a family doctor, or a child psychiatrist to go ahead and do the trial. We explain to everybody that this is only a trial and that it's got to be followed up. Follow-up on medication is absolutely crucial. Studies of follow-up have shown, for example, that it's rotten. One study showed that the number of contacts between a prescribing doctor and a family after the prescription, 6 months after the prescription, the number of contacts on the average these families had with the doctor was 2. I mean, 2 phone calls in 6 months. That's terrible. You never do that. So you find a doctor who's going to do it. You try and determine your initial dose. A good way of doing that is you take the child's body weight, divide it by 4. So we have an 80-pound child, divide that by 4, you get 20. You divide that into 2, and with Ritalin, that would be your estimate of what would be the amount per dose for that child. So you would guess this child would have a therapeutic response at 10 in the morning and 10 at lunch. But it's only a wild guess, and body weight formulas are only rough estimates. But that 80-pound child, we wouldn't start on 10-10. We'd start them on 5-5 because some kids are much more sensitive, so we'll go down. We have a 50-pound child. We're going to start that child on 2.5. Take those little yellow pills and cut them. Some people don't think to cut those little yellow pills, the 5-milligram tablets. You can cut them. It's not easy. You know, you put a knife on. You ever had the experience? You put the pill on the counter, You get that knife and you go like this, you take off your glasses and you go right for the score and you hit it, and sure enough you cut it. One half goes down the disposal, the other half goes onto the floor. The dog gets it and he's real calm for the rest of the morning. They do have pill cutters that you can get. So anyway, so you start with this one dose, you estimate it. What do? You go 3 to 5 days on the first dose. If you don't get therapeutic effects or side effects that are intolerable, you go up to the next dose. With the little kids under 60 pounds, with Ritalin, we go up by 2.5 milligram increments. With kids over 80 pounds, we go up by 5 milligram increments, and in between, we kind of play it by ear. Every 3 to 5 days. Don't start a dose of Ritalin and start on 5 milligrams, and the doctor says, call me in a month. You don't do that. It's call me in a week. You can adjust the stuff very, very quickly. We have people sitting around all year while their kids are disintegrating, adjusting these medications when it could have been done quickly. Now, with clonidine and the antidepressants, it's not as fast. But with the stimulants, it's very, very fast. How do you find out if it's working? Find out if it's working by talking to the teacher, the parents, and the child. And usually the teacher and the parents are more reliable. A lot of times the teacher and parents will say, I can't believe it, this kid's great, it's just wonderful, totally different child, that's just tremendous. And so you think, well, this is good. Maybe this is a therapeutic dose. You talk to the kids will say all kinds of stuff, and they are really funny. Sometimes you will get the parents and the teachers saying, this kid is great. You talk to the child and say, do you notice any difference with the medication? Nah. You say, why would the child just say that? Well, one reason is ADD kids are not good historians. Another reason is some of these kids admitting that there's an improvement with the medication is the same as admitting that there was a problem in the first place. And they're not going to admit that. And then we have the story of one little boy from Florida that I always enjoy telling. 7 years old, his mother writes a letter and says, the happiest day in my life was when my 7-year-old went on Ritalin for the first time. Teacher called her at lunch and said, this kid is great. No more of the hyperactivity. He's focused. He's not bothering other kids. The improvement is dramatic. The mother can't wait to talk to the child when he walks in the door. 3:45, the little 7-year-old walks in the door. Mother says, well, how was your day? It was okay. Take the medication? Yeah, I took the medication. Did you notice any difference? No, didn't notice any difference. You didn't notice any difference from the medication? No, I didn't notice any difference. But you know, for the first time, the teacher didn't drive me crazy. So we'll take it, we're not proud. We'll say, we're not going to say to that, come on, buddy, you know it was you and all this kind of stuff. We'll take whatever gains we get. It's a tough business. And a child's happier. And sometimes you can see a gleam in their eye, even when they're denying it. You know they're happier, and it's very good. What about medication holidays and long term? A lot of kids are off the meds on the evening. Stimulants can cause insomnia if they're taken too late. A lot of kids are off the meds on the weekends, and a lot are off during the summer. How do you decide if you're going to take your child off during the summer? There's a very simple rule, I think. During the summer, you don't have school a lot of the time, so you don't need the concentration benefit. Okay, so you say, well, we don't need it for concentration. But do you have a child who has a major behavioral or social benefit from taking the medication? If you have a child who has a major social and behavioral benefit, I'd be inclined to keep them on the medication during the summer. In my experience, I've seen too many kids disintegrate during the summertime because the doctor insisted medication holiday during the summer. No way he's staying on this stuff. And a kid goes out and he starts fighting again with his friends. He has a terrible time during the summer. I don't think that's fair to the child, especially if the medication is safe. So your holidays, you can do that. You can do an in-between routine for weekends and summers, and that is you just do it as needed. Most of the time the child maybe doesn't take the medication, but he takes it for Sunday school. He can take it for soccer. Do you know Ritalin? And these can help ADD kids for sports. You ever seen your kid space out on a soccer field or playing left field in a baseball field? And he's watching a flock of geese. There's a mother goose with 6 babies. Isn't that interesting, And the ball goes over here, 3 runs score, and the team loses the game. And you're there like this, I can't stand it. So you can take it there. So you can do what we call kind of PRN use or as needed use, provided it's okay with the prescribing doctor. What's the long term? Parents always want to know, is my child going to be on this stuff for the rest of his life? The answer is, we don't know for sure, but I can tell you how to guess. If you have a child and he goes on a stimulant medication and he has a good response, no side effects, we usually like to keep him on for about 2 years. At the end of 2 years, what we're going to do is we may try a medication holiday, but never in September and never around the holiday times, because these kids are screwy around the holiday times or their birthdays. What are the chances that a child, after 2 years of positive response to the medication, will be able to successfully discontinue? The odds are 25%. Now, it doesn't sound like a lot, but in 4 years, it's even money that the child's off the medication. Okay? So if he starts taking it in 2nd grade, good chance he'll be off by high school. Now, some of those kids may have to go back on when they hit high school geometry or world history and the material becomes harder. They may have to go back and take the medication again. Now, sometimes people say, too, well, how can he go off the medication if you said ADD is not curable? I don't really know the answer to that. I can guess. Maybe he had a milder case of ADD. It's not all or nothing. It comes in degrees. Maybe he was smarter. Maybe in the time he was on the medication, he learned a lot of positive habits that were reinforced enough that he can continue on the right road without the assistance of the medication. So the long term, you don't really know. Some of the kids will need it straight through. My son is in college and graduate school now, and he still takes the medication. Other kids will be able to go off sooner. So you really don't know, but you can try it every once in a while. You can usually tell pretty quickly if a child is not ready to go off. You may have had accidental medication holidays. You know, an accidental medication holidays? You forget to give it to him, and you get a call from the teacher at 9:30. Did he take the medication this morning? That kid's not ready. Sometimes you can tell by the child's behavior on a weekend. He's just a wild man. When you don't give him the medication, he's probably not ready. But please don't do a medication holiday in September. I hate it when people get together with a pediatrician in August for the physical. Doctor says, how was your summer? Mother says, oh, pretty good. Was he taking the medication? No. Well, I tell you what, he seems to be doing pretty good. How about we start him in the school year without the medication and see how he does? That is not smart. You know why it's not smart? School and summer are two different things. You don't have to concentrate during the summertime, but you do have to concentrate during the school year. That is setting the child up for failure, and I hope I never hear about it again. But we keep hearing about it, so please don't ever do that. What are the possible positive effects of medications? Especially with the stimulants, the possible positive effects of medication can include just about anything that's a symptom of ADD in the first place. But it doesn't necessarily mean that you're going to get results. We expect fairly good results with about 75% of genuine ADD kids with a stimulant medication. And they can show improvements in things like attention, impulsivity, sometimes their social life. They can make less noise. They can be less disruptive. A whole lot of things like that can improve. Does their IQ go up? No, but their grades will go up because they can use it better. And in sort of a disappointing vein, there are about 20 or 25 studies in the research that show that their achievement test scores on the Iowas and things like that do not go up even after several years treatment with stimulant meds. We don't know the reason for that, but don't expect your child's achievement test scores to necessarily improve. Now, what about the negative side of the ledger? Talk about the positive effects of Ritalin. What are some of the negative ones? Well, there are side effects to any medication. Keep in mind, anything you put in your mouth could hurt you. You can have toxic effects from megavitamin therapy. I could show you articles about aspirin that would make you never want to take another aspirin. Some of you know what the PDR is. The PDR is a physician's desk reference that describes all the legal drugs in the United States. You read the PDR on any medication, you won't want to take it, because it describes just about every side effect that ever happened to a rat, dog, monkey, or human being. And so it's not very encouraging. But the United States is the most conservative country in the world when it comes to approving meds. So if they're approved by the FDA, you can bet that it's a pretty safe medication that you're talking about. Possible negative effects, appetite suppression, almost universal. We usually live with it. These are stimulants. Stimulants suppress appetite. A lot of the kids will make up for it at the end of the day. They may not eat too much lunch, but they'll come home and they'll pig out anywhere from 4 to 8 o'clock and make up for what they didn't eat at lunch. Breakfast, try and give them the medication with the meal so it doesn't suppress the breakfast appetite. Insomnia can be a problem with the stimulants. Rarely do we run into this because we usually don't give it to the kids too late in the day. And interestingly enough, even some kids that do take it, say for soccer at 6, still can go to bed at 10. So the insomnia, don't consider it a for sure thing. The insomnia may or may not occur with any particular child. But we usually try and stay away from giving it to them at the end of the day. Headaches and stomach aches can occur with the stimulants and with other meds. Just about anything you take on an empty stomach could cause a stomach ache. The headaches and stomach aches will usually diminish over a period of time. So if you get them in the beginning, we usually try and weather that and see if we can get through it. Sadness and irritability. Occasionally you'll get a child who will take stimulant medication and he will get sad and irritable. Instead of a better child who's concentrating more, who's calmer, you get this whiny, moody, irritable, feel sorry for myself, nothing's right, everything sets them off. That's a bad effect, and you may have to discontinue the medication. A few kids will have a side effect of becoming more hyperactive, although that's rare. Very few kids will get the tics that I talked about, and some kids will get more anxious if they take the stimulant medications. It's been estimated that the meds can work well for about 75% of ADD kids. 25% dramatically, 25% of those moderately, and 25% kind of mildly. 25% no effect. It's also been estimated that only about 3% of kids have side effects that are so bad that it prevents them from taking stimulants. But that does not mean that it works for 97% of those children. As I mentioned before, using the medications is your choice, and you have to know the facts so you can decide for your child. Before we close, I just want to tell you one little story and say one thing. If you do have an ADD child, you do have a long road ahead of you. If you do have a 6-year-old, like I said, you've got 12 years. These kids always seem to keep you off balance, but there is a light at the end of the tunnel. I can tell you a story about a couple I knew once, and they had an ADD child, and he had run circles around him for years and years and years. He hits 18, and he graduates from high school, and it's time for him to go away to college. The day comes when Mom and Dad are going to drive this boy to college. They're laying there in bed in the morning, the day they're going to drive this kid, and he's going into a dorm, the day they're driving him away, laying there in bed in the morning. Husband wakes up listening to the sound of sobbing next to him. Wife is all upset. Her baby is going away to school. The husband is laying there. He's excited. He's thinking today is the day. I know these people. It's not that they don't love their child, but there is a light at the end of the tunnel, and they've told me their house is much calmer since. The child's an hour away, comes home. On weekends, they can still get together and still have a good time, although it's an adjustment when they come back after they've been away for a while. But there is a light at the end of the tunnel, and the prognosis for a lot of ADD kids is good, especially if you follow some of the guidelines that we have talked about today.
The main experience I've had with medication is basically Ritalin, students taking Ritalin. I've seen it do a lot of really good things as far as getting the students to focus in on their work.
It helps me stay calm, and it helps me from saying the answers without raising my hand.
It can help me do my work a little better.
Well, the effect of the medication on CJ was pretty dramatic. We remember very vividly the situation of his first day at school, and the ensuing 2 or 3 days. It was like the difference in night and day, wouldn't you say?
Absolutely.
I mean, he was off the wall, literally, getting up, walking around in a social situation, not following direction, talking nonstop, just, you name it, he was doing exactly the opposite of it. We really were very fortunate. We didn't have a long trial period with the Ritalin. We started out with the first dosage level that the neurologist suggested, and it worked.
Yeah, we did not tell the teacher the first couple of days that he was on medication. We were working a behavior mod program with him, and I went and picked him up every day, and she would tell me how the day had been. And the first day I went to pick him up that he was on medication, she said, "We had a pretty good day today." And the second day she said, "We had a wonderful day today." And the third day she grabbed me by the arm and said, "What are you doing? That's different." And I told her then that he was on medication, and she literally threw her arms around me and said, "We're going to have a wonderful year."
So with that, if you do have an ADD child, I want to thank you for listening, thank you for your attention, and best of luck to all of you.
Whether you are a parent, teacher, or medical or mental health professional, we hope you are now well on your way toward knowing all about attention deficit disorder. There's always more to be learned, though, and new information appears all the time. So if you have an ADD child or work with ADD children, don't ever stop searching, reading, and talking to others.